Hi everyone, our subject today is urticarial rash in pediatrics. Basics. Urticaria are a blanchable, transient, purpuric, circumscribed area of edema and erythema involving the epidermis and dermis, which can have central pallor, commonly called hives. Urticaria are caused by several mechanisms, including IgE-mediated allergies, non-IgE-mediated reaction, autoimmune disease, and environmental triggers. Urticaria may be classified clinically as acute, lasting less than 6 weeks, or chronic, lasting 6 weeks or more. Urticaria can occur in the setting of anaphylaxis, a systemic allergic reaction involving two or more organ systems. This lecture describes isolated urticaria in the absence of other symptoms of anaphylaxis, such as wheezing, airway edema, vomiting, or shock. Urticaria affects 6 to 7% of preschool children and 17% of children with atopic dermatitis. Acute urticaria is more common in children and young adults. Chronic urticaria more common in adults than children. History. History is the most important tool in determining a cause of urticaria: duration, timing of lesion, location of lesion, patient and family history, suspicion of precipitated exposure, pruritus, family and personal medical history of angioedema, atopy, prior urticaria, wheezing. For acute urticaria, ask about possible precipitant, exercise, food, shellfish, fish, egg, milk, soya, peanuts, cheese, chocolate, nuts, berries, and tomatoes. IV contrast media medication include antibiotics, diuretics, aspirin, nonsteroidal anti-inflammatory drugs, iodides, bromide, quinidine, chloroquine, vancomycin, INH, antiepileptic agent, and other agent. Nickel, like jewelry, dimming jeans, button, rubber, like gloves, elastic band, latex, perfume, hair dyeing, detergent, lotion, creams or clothes, pets, dust, mold, chemical or plants. Pregnancy usually occur in the last trimester and typically resolve spontaneously soon after delivery. Recent illness, fever, sore throat, cough, rhinorrhea, vomiting, diarrhea or headache, sun or cold exposure, travel, risk for acquiring amoebiasis, ascariasis, trichinosis, strongyloiditis, malaria. For chronic or recurrent urticaria, chronic medical conditions, precipitants such as heat, cold, pressure, exercise, sunlight, emotional stress, symptom to suggest an underlying systemic disorder, fever, weight loss, joint pain. Physical examination. Typical finding in urticaria: blanchable edematous papule or wheal. Border may be syringitis. Dermatographism, generalized or localized. Size from 1 mm to many centimeter. Giant urticaria. Size from 1 mm to many centimeter, giant urticaria. Signs so occurring with the urticaria that suggest a systemic reaction, anaphylaxis, requiring different treatment from isolated urticaria. Angioedema, hypotension, respiratory distress, stridor, vomiting, wheezing. Investigation. Acute urticaria, no investigation are required unless suggested by history. If there is suspicion for urticaria related to food allergy, IgE-mediated reaction can be confirmed, usually on follow-up with an allergist by skin prick testing. Must stop antihistamine prior to having skin testing and CAP fluoroimmune assay, previously called RAST on blood. Investigation of chronic urticaria. Also, no investigation are required for the majority of patients with a mild disease that respond well to H1 antihistamine agent. Goal of the evaluation are to exclude differential diagnosis, evaluate disease activity, and detect triggers or underlying etiology. There is limited utility in obtaining laboratory tests. Guidelines propose a limited screening for systemic disorder, CBC with differential, C-reactive protein, ESR, TSH level. Further laboratory testing in the emergency setting has a low likelihood of identifying underlying medical disorders. A skin biopsy should be taken from a new lesion if urticarial vasculitis is suspected. May be deferred to follow-up evaluation. Challenge test for physical urticaria called urticaria may be induced by applying ice to the forearm for a few minutes and then allow the skin to rewarm. Scratching the skin lightly may induce dermatographism. Etiology. Acute urticaria etiology undetermined in more than 60% of cases. Emotional stress, environmental factors such as heat and cold, latex exposure, exercise, food, infectious, including mycoplasma pneumonia, parasite, viruses, medications. Chronic urticaria etiology undetermined as many as 80 to 90% of cases. Autoimmune, including hyperthyroidism, rheumatoid arthritis, SLE, infectious, including syphilis, viruses, neoplasm and blood dyscrasia, including cryoglobulinemia, lymphoma, polycythemia vera. Other causes: amyloidosis, familial cold autoinflammatory syndrome, mastocytosis, Muckle-Wells syndrome. In children with henoch-Schönlein purpura, the rash usually begin as macules or urticarial lesion, later become raised and petechiae or purpuric. Lesions are usually concentrated in the buttocks and lower extremity, a gravity-dependent area. Involvement of the other organ system, GIT, renal, neurologic, suggest the diagnosis. Treatment. First line, first generation antihistamine, diphenhydramine, hydroxyzine. Second generation H1 antihistamine, cetirizine, loratadine. Less sedative than the traditional first generation antihistamine and are preferred over the first generation as first line therapy. Off-label use, famotidine and ranitidine. Second-line treatment, prednisolone, generally reserved for patients with the prominent angioedema or ongoing symptom despite antihistamine. Prolonged course should be avoided when possible. Tapering regime may be helpful. Peers and pitfall. Antihistamine agents are the mainstay of therapy. The cause of urticaria is often idiopathic. Failure to recognize anaphylaxis, including failure to perform a careful assessment of the airway and breathing. Thank you for your listening.